Okay. Welcome everyone to the Spirometry and Primary Care webinar. Dr. Manaj Menon, Assistant Professor of Medicine, Division of Pulmonary, Critical Care and Sleep Medicine, the Department of Biomedical Informatics at the University of Buffalo, is our presenter today. Welcome, Dr. Menon, and thank you for your time.
Thank you, Janet. Thank you for having me present this very important information to our primary care providers. So for this presentation, we took a lot of the information from the Global Initiative for Chronic Obstructive Lung Disease of GOLD. And so the GOLD Initiative for Chronic Obstructive Lung Disease has updates. We're using the slide set from 2010 because they haven't made new slide sets since then. But the information is valid and concurrent with the 2018 updated guidelines. So spirometry, this introduction, it's the gold standard for COPD diagnosis. It's also the standard for asthma as well, but for the slide deck, they will concentrate on COPD. Underuse of spirometry leads to inaccurate diagnosis of COPD and asthma, and widespread uptake has been limited by several things that I think everybody here on the presentation understands. Concerns over technical performance of the operators, basically whether the people actually doing the spirometry on patients know what they're doing, difficulty with interpretation of results, whether the providers who interpret the results understand what the results mean, lack of approved local training courses, and lack of evidence showing clear benefit that spirometry is incorporated in management. And I'll try to hopefully account and describe how using TFTs and spirometry specifically can help you with management of COPD and asthma. So just to clarify and just to define, spirometry is a method of assessing lung function by measuring the total volume of air the patient can expel from the lungs after a maximal inhalation. And so people may ask, why do you perform the spirometry? And it's good to know why you're doing it when you're doing the test for a patient if someone else asked you to do the spirometry. One is to measure airflow obstruction to help make a definite diagnosis of COPD. Also, it's used in asthma and other lung diseases as well. Confirm the presence of airway obstruction. Assess the severity of airflow obstruction in COPD. And because the slide deck is concentrated on COPD, it's same COPD, but we also want to make sure everybody understands you can use it for asthma as well. To detect the airflow obstruction in smokers who may have few or no symptoms. Monitor disease progression in COPD. Assess one aspect of the response to therapy. Assess the change or prognosis with the change of the FEV1, and we'll go into detail what that means in COPD. And in some cases, perform preoperative assessment. So you can also use spirometry to make a diagnosis and set severity in the range of other respiratory conditions. I mentioned asthma. There's lung fibrosis and some respiratory muscle weakness diseases that you can use with spirometry to help aid your diagnosis. You can distinguish between obstruction and restriction that's cause of breathlessness. You can screen workforces in occupational environments with the Tonawanda issue in the news and Bethlehem Steel in the past. There's other occupational lung diseases that would require screening the workforce on a regular basis. Assess fitness to dive and perform pre-employment screening in certain professions. So I'm just going to give you a brief overview of the spirometers that's out there. There's a bellows spirometer, which you won't really see unless you're in a formal lung function lab, maybe mostly at the hospitals and the pulmonary doctor's offices, and they measure lung volume in a very sophisticated manner. Electronic desktop spirometers, which is what I would recommend primary care practices to purchase and use, measure flow and volume with real-time display and ability to print out those results. And then there's small handheld spirometers, which are inexpensive and quick to use. They have no printout. Sometimes that may be for a quick on-site clinic visit for someone who has a lot of patients with lung disease, or in some cases can be used by patients. But for the purpose of this talk, I would say the primary care folks should focus on the desktop spirometers. And this is a picture of one type of desktop spirometer, and this is another. There's kind of ranges and variability in how it looks like, but they get the job done, and there's extensive manuals and description on how to use them and how to calibrate them. And then again, another type of desktop spirometer. These are small handheld spirometers. And although they are functional and can give you some of the values we're talking about, they don't provide a written or printed document of the spirometer results, and that's difficult to use in a clinical setting because then you can't. It's hard to document that in your EMR and to then request reimbursement. So I'm going to give you the standard spirometer indexes that what a physician or a provider should look for in the spirometer. One is the FEV1. It's an acronym that stands for the forced expiratory volume in 1 second. When you take a deep breath in and blow out, most of the air that you blow out comes out in the first second, and it's very important physiologically. So it's one of the things that we should look for in most lung diseases. The other indices that we look for is FVC, which is the forced vital capacity, and that's the total volume of air that can be forcibly exhaled in one breath. So FEV1, how much you breathe out in the first second, and FVC is the total volume that you breathe out totally in one breath after you take a maximal inhalation. And then there's a ratio of FEV1 over FVC, and that's the fraction of air in the first second relative to the total volume you exhale. And that gives you a measurement of how obstructed your airflow is and can help us diagnose if somebody has COPD or asthma. There's additional spirometric indices that are listed in spirometry reports, so I just want to go over them quickly. They're not as useful for the diagnosis of COPD and asthma and other lung diseases for the primary care provider. We may use them in subspecialties, but I just want to let you know what it is in case you're wondering what these acronyms are on the report. One is VC, or vital capacity. It's about a full volume breath exhaled at a patient's own time and not forced. And it's often a little bit increased versus the FVC, especially with COPD. There's physiological reasons for that. It's something that maybe a subspecialist will look into, but for the purposes of COPD, you don't look at the VC, you look at the FCC. For FEV1, FEV6 is the forced expired volume in 6 seconds, and it approximates the FVC. There's physiological reasons for that. Patients with COPD may exhale for more than 6 seconds, sometimes 10 seconds. There's some 1 or 2 patients I have who take 15 seconds to fully exhale because of the lung disease. But current evidence doesn't clarify whether we should use that or not, so you still use FEV1 and FVC. And then there's mid-expiratory flow rates. It was used in the past to help people to figure out if somebody has small airways diseases, and sometimes they call it MEFR or mid-airflow rates. It's derived from the mid-portion of the full volume curve, but it's not really shown to be helpful for COPD or asthma. So even though it's there, and some people have used it in the past, it's not in the current evidence been shown to help for either diagnosis. And so just for people to understand when I'm talking about the different volumes in the lung volumes assessment, if you imagine your total lung capacity on this graph from the top and bottom lines, when you take a breath normally, you're actually in the middle point of your capacity. You have some air in your lungs, and you are breathing at a consistent rate, probably about 20% of what you can likely totally breathe in and breathe out. And that's considered tidal volume, breathe in, breathe out. If you take a deep breath in, you go up to total lung capacity, and the difference between your normal tidal volume capacity and the total lung capacity is this inspiratory capacity. And you may do that right before you take a deep breath out to blow out candles on a birthday cake, okay? And then when you take that deep breath in and exhale as hard and fast as you can, that's the vital capacity, okay? Or forced vital capacity. And so if you notice that going from that top to the bottom of the vital capacity, you still have air in your lung, and that's the residual volume. And we all have air in the lung, even if we try to blow out as much air as we can. That's there's physiological reasons for that. What happens in COPD and asthma is there's increased residual volume. We're not blowing out all the air out, and so there's detriments to your health because of that, but that's on another session that we could talk about. Going from the vital capacity to the residual volume, there's the expiratory reserve volume. So even when you're breathing out and you exhale normally without being conscious about it, you have more to exhale. We do all of this automatically, but we can take over this with voluntary control. And so I just want people to consider that when they ask patients to go up to total lung capacity and exhale, what we're trying to do is trying to find the vital capacity. And there's certain different patterns on the spirogram or spirometry that we're going to go over, just so everybody has a foundation for interpreting spirometry, even if you're just performing the spirometry for another provider. And I know that MCC was planning to do hands-on training with everyone, so this will help you hopefully have a foundation before the hands-on training. So there is predicted normal values, so I'll go over that. So I want everybody to realize, I'm going to spend some time on this predicted normal values are affected by age of the person, right? Height, sex, and ethnic origin. So I'll go over this in a little more detail. If you look at, go back to the prior slide. You look at the picture, I wanted this to understand, right? If you think about yourself when you're 30 and your eventual future self at 80, you may, over time, get kyphosis, you may have scoliosis, and your chest is going to decrease. So your lung capacity is going to decrease over time. So your height changes, and because your body type changes, that's going to affect your lung volume. Second thing is, women and men are different in terms of lung capacity because of our ratio of our legs to our chest. So there's a little difference in there. And ethnic origin. So there's certain ethnicities that have longer legs than torsos. African Americans, South Asians, Hispanics may have different ratio of hip to feet ratio to hip to head. And that's important because really the lungs are what occupies the chest cavity. And so if you have smaller chest cavities, even if your height is the same as someone else, that's going to affect what the predicted normal value is. And so it's very important then the initial documentation phase to get the right height, the right age, and make sure you got the closest ethnicity you can. And because otherwise there may be a huge difference in what the normal range is for that person. So the criteria for a normal post-bronchodilator spirometry is an FEV1% predictor around greater than 80. There is something called the NHANES, and I'm not going to go into what it stands for, but the NHANES survey of healthy individuals that gives you what a normal range of percentages are for a lot of different metrics, including FEV1 for a given population. And so you would have a normal range for FEV1 for a certain ethnicity, age, and sex. It depends on your spirometry if that's how it's set up. So you can either set it up by strict goalposts, like 80% is normal for FEV1, or you can have it where you have it between a confidence interval where 95% of the normal folks will have this range, and that's what's considered normal. And so for your clinic, you have to decide whether you want to have the standard goalpost, like the 80%, or do you want to have the confidence interval that spans 95% of what's normal. FVC is also about 80% is considered normal, and FEV1 or FVC, there's a range, 0.7 to 0.8, depending on age, because it's younger you are, it should be 0.8, the older you are, 0.7. I say for the purposes of primary care docs, 0.7 is appropriate for the cutoff for airflow obstruction. Okay, and so when you see a normal tracing for FEV1 and FVC, and there's several different graphs. So one graph I want you to look at is the graph that has time on the bottom axis in seconds and volume in the vertical axis, okay? And if you see, and if you imagine you take a deep breath and blow out, and you're trying to measure how much volume air you blow out over time, this is the curve that should arise. It looks like you are breathing out mostly air in the first second, and it's a nice rounded curve to a flat line. So at a certain point, you're going to reach the maximum amount of air you're going to blow out. So in here, you can see in 1 second, the person blows out 4 liters of air. In 6 seconds, which is the cutoff for FVC, is the 5 liters of air was blown out. And the ratio, if you take the ratio of FEV1 or FVC, is 0.8. And that's what the machine does when it gives you the numbers. Now, let me give you an example with spirometry and obstructive disease, okay? So that's normal. You get that baseline. And then obstructive, for whatever reason, their lungs are not able to blow out air as fast as someone is normal. And so you can see the curve is more rounded, and it's pushed down into and it has less volume. So in 1 second, this person had 1.8 liters of air that was blown out, and then the person's FVC or air that they blew out in 6 seconds was 3.2 liters, and the ratio is 0.56. And so there's different diseases that can have airflow obstruction: COPD, asthma, bronchiectasis, cystic fibrosis. You can have it after TB or a bad pneumonia, lung cancer, which there's a greater risk of COPD, and certain other inflammatory lung diseases, one called obliterative bronchiolitis. And so for COPD, it's a diagnosis confirmed by post-bronchodilator. That means after you use albuterol, for the most part, for most primary care offices, and you see if the ratio is less than 0.7. And so you have to measure it about 10 to 15 minutes after using a single dose of a bronchodilator. Here they put salbutamol, but albuterol is probably the more common ones. When they have the hands-on training, they'll go over that a little bit more on the bronchodilators you can use, the inhalers versus nebulized medications. But albuterol is what you typically use. And then in the hands-on training and the pharmacy on-site training, you can discuss whether using albuterol inhaler versus albuterol nebulizer works for your clinic. So this use of spirometry before the bronchodilator is given and after is considered a bronchodilator reversibility testing, and it gives you the best achievable FEV1 and FVC. It helps differentiate COPD from asthma because when you have airflow obstruction that doesn't completely reverse with the bronchodilator, that's consistent with COPD. And if you have airflow obstruction that does completely reverse a bronchodilator, the pre and post are different and significantly different, and I'll go into how you determine if it is significantly different, then it's consistent with asthma. However, everything must be interpreted with clinical history. You cannot diagnose asthma simply just on spirometry alone. They definitely are necessary for the diagnosis, but there needs to be background history, case of COPD. In a prior session, we talked about this. You need to have a history of smoking and some type of exposure to a noxious element. It has to have time of that exposure. And asthma also has different background comorbidities and symptoms to help you distinguish if it's asthma. So bronchodilator reversibility testing can be done on the first visit. No diagnosis has been made, likely not on any medications. It's best done if you plan it, because you need to have time between the pre and post bronchodilator test, because you have to wait about 15 minutes. And so it's best to plan it and then plan other things you do within that 15 minutes. Patient education, training, surveys, questionnaires, vaccines. So those are the things you might want to consider planning ahead, so you maximize that time between the pre and post bronchodilator. It helps save time and also helps confirm if asthma is present, okay? So it's a good idea to do it because maybe somebody has asthma and not really COPD, and vice versa for the patient you're concerning asthma or COPD. One consideration is that you have to withhold short-acting bronchodilators for 4 hours prior to the test. Otherwise, it obviates the results, right? Then you're really not doing a pre-bronchodilator test, and it's hard to then use that to compare it to the post-bronchodilator test. You should make sure that testing for bronchodilator reversibility is done when the patients are stable and free from respiratory infection. So if they just had a COPD exacerbation, pneumonia, or asthma exacerbation, you really shouldn't do the bronchial reversibility testing because they have active inflammation in the lungs. You should not have taken the short-acting beta bronchodilators. It says here 6 hours. We have to use the slides of the Bold Foundation. So 6 hours before and 4 hours. I say 6 hours to be safe as well. The long-acting bronchodilator in the previous 12 hours, because that's how long they're supposed to be active for. And if somebody's on theophylline, if they're on the sustained release theophylline, which I think is the only one in the U.S. market, they shouldn't be on it for the prior 12 hours. If somebody's on the long-acting cholinergic agents like Spiriva or its cousins, the other pharmaceutical companies, I would say that you would want to wait 24 hours as well for those. And typically for inhaled corticosteroids, you would want to hold them for 24 to 48 hours. FEV1 should be measured, and a lot of these details will probably be going over again by the hands-on training that will occur at your site. But FEV1 should measure at least twice with less than 5% or 150 mLs difference between those two attempts. So you may have to repeat the spirometry effort if you don't have two measurements that are within 5% or 150 mLs before the bronchodilator is given. The bronchodilator should be given by a metered-dose inhaler through a spacer device or by a nebulizer, just to be sure and inhaled. It depends on your practice, logistics to see which one you would consider using. And the bronchodilator dose should be selected to be high on the dose response curve. So that pharmacy will help you pick which bronchodilator to use. And so when you say, hey, is this difference in the pre and post bronchodilator significant? What you look for is an increase in FEV1 that is both greater than 200 mLs and 12% above the bronchodilator FEV1. That's considered significant. You may have increases in FEV1 that's below this, and I wouldn't consider that significant. It's usually helpful to report the absolute change in mLs as well as percent change in baseline. And the rationale is that maybe even if it's not significant, that there is, even if there's a slight difference, like 5% and 100 mLs, maybe that's clinically important to the patient. So I want people to understand, yes, this significant bronchodilator response is necessary for and foundational to help you understand somebody has asthma versus COPD. But it doesn't mean that you can't give bronchodilators to people who don't have a bronchodilator response on the test and they won't benefit from it. That you would have to see after you attempt to try and prescribe the medication and see how they do. Okay, so we'll try to do some practical sessions here in the webinar, which will have further training and the hands-on training at your site. I want to just emphasize that training is essential for operators to learn how to correct performance of the patient and interpret the results. The Gold Foundation and committee recommend training for performance and spirometry about 3 hours. So if you spend time with this webinar and then do time with the hands-on training, that definitely accounts for the 3 hours of training. In order to get good at spirometry, you require practice, evaluation, review, and that's the rationale for the hands-on training that MCC is going to provide. And spirometry performance, who does it, when it's done, where is it done? It needs to be adapted to your local site and practice. So that's the rationale for MCC to send different individuals to your site to help folks understand how to do spirometry and how to deal with the logistics of performing the spirometry at your site. And then training for spirometry should be evaluated, and that's one of the rationales for the on-site training that MCC is planning at each site. So trying to get the predicted values, those predicted values isn't going to be independent of the type of spirometer. It's basically on several known standards and surveys that were taken of the U.S. population. Sometimes it's world populations. Choose values that best represent the tested population. So, for example, NHANES has a lot of the ethnic groups of the U.S., but then they may be missing out certain ethnicities that may be present in different standards of the international registries, and so you would, depending on the spirometer, they may have different standards available for you to pick. Most of them will have the NHANES standard for you to use. Check for appropriateness if it's built into the spirometer. I think for the sites that we're talking about, everybody should be okay for NHANES. For a place that may have a lot of refugees or different, more diverse populations, then a different database may have to be used. And then because spirometry is very effort-driven, you should have the patient rest 10 minutes before the spirometry, so they shouldn't be running from the car, from the parking lot, going to the office, and going straight to spirometry. And so again, in terms of planning, you would want to consider other activities for the patient to do, a sedentary activity before doing the spirometer and then doing the spirometer. And then if you have a bronchodilator given, you might want to have another activity for 10 to 15 minutes and then do the post-bronchodilator. So there's a little planning involved, a little just logistics involved, but if you get the workflow through, it probably should be beneficial for your practice and the patient. Again, this is another reminder of when to withhold the medications. You could give this as a little handout to the patient. Don't use your active beta agonist 6 hours before the lung function test, the spirometry. Long-acting beta agonists for 12 hours, ipratropium for 6 hours, tiotropium and other long-acting cholinergic agents for 24 hours. And pharmacy could give you an updated sheet. Perhaps you could laminate for your staff or a handout you can give to the patient when you schedule the PFTs or the spirometry. And they should avoid caffeine. Caffeine actually acts as a bronchodilator, so you should avoid caffeine and cigarette smoking for 30 minutes before the spirometry. When you see the patient and about to perform spirometry, you could again review the purpose of the test, demonstrate the procedure. So mimic in mind what the patient is supposed to do. Make sure you get the age, height, and gender, and enter in the spirometer. Again, I want to emphasize that. I've seen a lot of mistakes because maybe people put down the wrong height or the wrong age. Note when the bronchodilator was last used, you put in the comment section, it affects the interpretation of the results. Have the patient sitting comfortably, loosen any tight clothing, empty the bladder beforehand. Tell them if they need to use the restroom, they should go ahead, because the amount of air you take in and out is going to put a lot of pressure on your abdomen. And then, so if some patients have full bladder, they may have accidents. Not in this list of steps here, I would recommend having the person sit in a chair that can be cleaned with cappy wipes or bleach. So a vinyl chair or some type of non-porous chair, because of the amount of effort somebody takes. Some people may have issues with bladder control. So when you tell them to perform the spirometry, have them breathe in until the lungs are full, have them hold their breath, and then seal the lips tightly around the clean mouthpiece. Have them blast the air out as forcibly and fast as possible, provides lots of encouragement. You almost have to be a cheerleader, right? You have to be say, blow out, blow out, blow out, blow out, blow out. You have to be really helpful for them. Imagine when you have a birthday party for a child, and you have to tell them to take a deep breath and blow out. There's a lot of coaching involved, and it reminds me of those episodes when I see somebody in the spirometry unit. So it's not something you're not used to if you've ever been to a kid's birthday party. And you ask the person to continue blowing out until the lungs feel empty. Watch the patient during the blow to ensure the lips are sealed around the mouthpiece. Check to determine if the adequate trace has been achieved, and we'll go over some certain traces so you could have at least a foundation of that before the hands-on training. And repeat the procedure at least twice more until ideally 3 readings are within 100 mLs or 5% of each other are obtained. So this is considered reproducibility, quality of results. So if you have tracings that look like this, it looks pretty reproducible, right? It's 3 within 100 mLs of each other, and it looks fairly standard. And so you would say, hey, looks like you did the FEC 3 times, and they seem to be within the metrics that we're looking for. When you do spirometry and you take a deep breath and blow out as fast as you can get lightheaded. You may get a headache. You may get red in the face. You may faint because you take a deep breath and blow out. You may have a vasovagal attack, and you can have urinary incontinence. So those are okay. You can deal with them. The folks and the medical clinic should be able to deal with those type of episodes. You would want to avoid spirometry after a recent heart attack or stroke, because you don't want those side effects to happen after you had a recent heart attack or stroke. So I would say 4 to 6 weeks after a heart attack or stroke, acute heart attack or stroke, you would want to hold off on doing the spirometry if you can help it. And the most common cause of inconsistent readings is poor patient technique. It's because somebody didn't inhale properly, so suboptimal inspiration. Because somebody didn't exhale properly, so submaximal expiratory effort. Delay in exhaling, shortened expiratory time, or an air leak around the mouthpiece. So that's why you have to, the person performing the spirometry, you have to look at the patient and make sure that they're doing everything correctly and encourage them throughout the procedure so they don't have these quality control issues. And so this is more listing of the common problems: the inadequate and incomplete blow, lack of blast effort during exhalation, slow start to maximal effort, lips are not sealed around the mouthpiece, coughing during the blow, extra breath during the blow, that you have someone close the glottis, so the vocal cords, or obstruction of the mouthpiece by the tongue or teeth, and poor posture, the person leaning forward as opposed to sitting upright with proper posture to allow a full inhalation exhalation. In terms of maintenance of the equipment, that's probably needed for quality control. You have to make sure that they're regularly calibrated to check accuracy, every spirometry unit is different, so you might have to adjust it to the one that you have at your clinic. But calibration is usually performed with a 3-liter syringe. So you use that 3-liter syringe to confirm that the spirometry is also reading 3 liters of air for their coming in from the syringe. Some electron spirometers do not require the daily weekly calibration. You then make sure that you clean the equipment, and infection control is important. You check the instruction manual on how to do that. And spirometry should be regular service. You have to look at the manufacturer regulations. So each one is individual. So you have to just make sure you have a checklist for that particular spirometer. And so I'll give you some examples of unacceptable traces. You can take a look at these and make sure that you look out for those. Also, at the hands-on trainings you're going to have, they're going to go over some common tracings that are suboptimal and that you want to avoid. So if you look at what's normal in this volume over time curve, someone who goes in and just gives a puff, not really maximum effort, is going to look like the curve in white you see below. They're not really giving that maximum effort. That little dip that you see there, even if they have COPD, that dip that you see there that says the variable expiratory effort, that shows you they're not doing as much of an effort as they should be during that time frame. It should be a rounded curve, a continuous line that shouldn't have that bumps and valleys that you see there. They stopped at, like, say, 2 seconds. That's inadequate sustaining effort. Really, you would want them to continue to exhale and have that flat line to show that they're not, they may not have extra air to exhale. And, if you tell them to start, the start of the curve should happen at the meeting of the axis, right? And if they take time to exhale and there's a gap, you will see that little gap between the vertical line and the start of their actual exhalation. So that's considered a slow start. In this one, right, the person started exhaling and then stopped. And this is, so do you see that? That's what this is showing. It's not a nice curve that you saw on the top there. Next one. This is a slow start. So when you exhale, that line should go straight up because that's physiologically how our lungs are. When we exhale, a lot of the air comes out for a second, so you shouldn't have that the S appearance of this particular white line, and so that may affect the results. This is a common occurrence when somebody coughs during the exhalation, and then you can see how it may affect the interpretation of the spirometry. So when it looks like this, even if you don't know what the actual values are or the indices or what's normal, you can tell this is not acceptable, and you would want to ask the patient to repeat it. This is when someone is taking an extra breath during the actual exhalation maneuver. So they're taking a breath, they exhale, and then they may have stopped early, and then inhale again, and then exhale. So that you see that little after the white line flat lines and it goes up again. That's because the person took an extra inhalation, and the machine is supposed to at that time try to record exhalation. So they may have a leak and not put them out over the mouthpiece. Take a breath in. Either maybe they didn't have nose clips and take it through the nose or a mouth, and then exhale again. So it's not a true measurement of the FVC or FE1. Next. And so, this is really meant as a resource and foundation for folks in terms of interpreting and providing spirometry. We want to make sure that folks who actually do the spirometry and for their patients understand the rationale for doing spirometry, understand what some elements of quality control entail, that you have some of the foundations of the tracing that you want to look for and avoid in doing spirometry. And then there's other guidelines and resources you could look online, and here are some of them here on this slide. And then the person who comes to your site for hands-on training can give you a little bit more walkthroughs through the unacceptable tracings. And I highly encourage you, if you've been doing spirometries at your site, to hold on to some of them to showcase what you have done before and what you considered good and what you considered bad, and what you thought was going on with the bad tracings. And so the person who's going to be on-site, the on-site trainer, can help walk you through what you can have done to prevent those type of episodes. In the end, I think there's a learning curve to doing spirometry, but once you got the hang of it, it's fairly easy to do. If you're motivated and you understand the rationale for doing spirometry, it really will help patients with COPD, asthma, and other lung diseases. And if somebody is a questionable spirometry and not quite sure what it is, we're happy to help out in the pulmonary field to figure out what's going on with the patient. But for most folks, diagnosis of COPD and asthma can occur in the primary care office.
That completes our spirometry training for primary care. I want to thank Dr. Manin on our behalf for doing this presentation. If any of the partners in the primary care offices have any questions regarding this presentation, please reach out to your relationship manager. Thank you and have a great day.